I am shocked that somehow it's already been 3, 4, 5 weeks. Is it 5 weeks that you guys have been in Durham?
Yes.
Woo! 5 weeks that Baraka, Winnie, and Miriam have been with us here in Durham, which I don't want to admit means that they're gonna be leaving us soon. But we're gonna hear from Baraka and Miriam, yeah? Is she joining online?
Yeah.
Okay, awesome. About their scholarly projects, but also hopefully a little bit of reflection about their time here in Durham. So without further ado, I will turn it over to you guys. Everybody. Are you gonna start or is Miriam?
I'll start. Remember to take your sound off. Yes.
It will likely do it automatically, but you can leave computer audio or leave meeting audio.
Good.
Let's see. But not just mute, like you probably need to leave though. It says like this, leave computer audio.
Leave your audio. All right.
Very good.
Okay. Good morning, everyone. Thank you, Ashley, for introducing me to the group. So my name is Baraka Moshi, a PhD candidate from KCU. I'm glad to be a part of the GEMINI group. So today I will share you just a brief of my PhD project with the title on assessing burden and rehabilitation needs pediatric injury patients at a tertiary hospital in northern Tanzania. So why do I think about this study is important? So at the end of the day, I want to come up with a scale which will aid to improve the health provision to this pediatrics patient after the injury. Also, I want to assess the barriers toward the rehabilitation service provision to pediatrics with the injury and zone referral hospital. Also, I want to come up with to know the needs, rehabilitation needs to this pediatrics injury. So at the end of the day, I also want to quantify the burden due to this injury so that I'll come up with the intervention. So the intervention will depend with the findings in the DALY's estimation. So it can either be primary intervention or secondary intervention. Depends on the findings of this result. Today, I'll concentrate more on the preliminary results of my PhD project so that I can get the inputs and advice toward the improvement of this project. So, trauma is among the leading cause of morbidity and mortality among children globally, with almost 95% of this injury-related deaths occur in low and middle-income countries, including Tanzania. Approximately 800 of the children die every year as a result of injury. In Tanzania, where the study will be conducted, pediatric injuries accounted for nearly quarter of all injuries. Yet, an estimated 50% of the patients in low middle income countries who need rehabilitation service do not receive it due to some factors, including the human resource and some other infrastructures. So despite the alarming prevalence of pediatric injury, there is no clear guideline for rehabilitation management for these pediatrics after injuries. So no understanding on how rehabilitation service are integrated in the overall injury care protocol in the hospital setting. So there is limited research on the long-term outcome on the quality of life of pediatric patients after injury. So this study aimed to assess the burden, rehabilitation needs, pediatric injury patients at a tertiary referral hospital in northern part of Tanzania. So the specific objective, I will mainly focus on 4 specific objectives. So the first 2 specific objectives, it will be secondary analysis of the pediatric trauma registry data. In just a nutshell, the pediatric trauma registry was established in November 2020 with the aim of giving the insight of epidemiology, outcome, and check on the factors influenced or factors associated with the poor outcome so that to improve the service provision to this group. So in my study, I will utilize data from November 2020 to June 2024. So up to June 2024, the pediatrics registry include 1,000 pediatric injury patients. So in the secondary analysis, I'll use 1,000 pediatric injury patients. So the objective number 1, I'll try to estimate the disability adjusted life years, pediatric injury patients at the zonal referral hospital in northern Tanzania. The DALY's estimation is quite complex analysis as it includes so many procedures and some issues to consider. So according to global burden of the disease, the DALY's can be estimated by 3 different approaches, whereby you can use prevalence approach, incidence approach, or the combination of 2 approaches, which we call it hybrid, whereby you utilize incidence and prevalence approach together. There are some key issues to consider while estimating the DALY's. One of the very important issues to consider is assigning disability weight to each condition. So the first thing, I did assign the disability weight to each condition of this pediatric injury, whereby I use a global burden disease report of 2015 to identify this disability weight. The other issue is to consider the country life expectancy. So I consider the life expectancy of Tanzania stratified by gender, both male and female. Also, I got further to check on the discount rates. When we're calculating that, there are different discount rates, 6% discount rate, 3%, and 0 discount rate. So the discount rate is taken into consideration that the future life way less as compared to the present life years. So many literatures has encouraged, or they have proposed that 3% discount rate to be perfect in the health-related research. Also, in calculating DALY's, I consider also the age weighting, so that at the end of the day, you weight according to the age of the patient. Then, after having those, I come across DALY's is a summation of years life lost and years of living with a disability. So, at the end of the day, I have calculated the DALY's according to gender, male and female, and at a different condition. So, at the end of the day, I will know the burden of this injury at the different age group, at the different mechanism of injury, and also stratified by gender. The second objective, try to evaluate the psychometric property of the patient-specific functional scale for the assessment of pediatric discharge after trauma at the zonal referral hospital. PSFS has been confirmed to be one of the reliable scales to assess the functional change at the different time points. So for this study, PSFS, the patients or parents were assigned to select 3 to 5 activities the patient used to perform before the injury. And these activities were rated at 0 to 10, whereby the more score, it means the good function. And this PSFS were evaluated at 3 time difference. So at the discharge point, we evaluated the PSFS, also 2 weeks after discharge and 3 months after discharge. So there are so many psychometric properties, but for this study, I mainly concentrate on the 2 main psychometric properties, whereby I concentrate on the validity and reliability of this PSFS, so that at the end of the day, you know, if this PSFS is a reliable tool or scale to be used in our setting. So also, I'll use the trauma register data for analysis of this objective number 2. So objective number 3, I aim to determine the knowledge, attitude, practice, and barriers of healthcare providers on pediatric rehabilitation needs at the zonal referral hospital in northern Tanzania. This will include the primary data collection, whereby my study participant will be a selected healthcare workers from KSMC, zonal referral hospital. But if you look on the objective, I'll be focusing on the knowledge, attitude, and practice. So in this way, I will use the quantitative data approach. But in the barriers, I will use a qualitative approach, whereby the study population on the barriers, it will include healthcare workers and the parents of those patients with injuries. So so far, we don't have the CAP survey tool in our setting, even in the low and the middle income countries. What I did, I created the CAP survey tools, which is on the process, so that it aid me in the data collection of this objective number 3. I'm planning to start a data collection maybe at the first week of December, if everything goes well. So the objective number 4, I will aim to assess the needs of rehabilitation to this group, so that at the end of the day, to see if there is unmet needs on this pediatric injury patient. So coming up to the preliminary result so far, coming to the social demographic of the study participants of 1,000 pediatric injuries, the median age was 7 years. Majority of the pediatric injured patients were men. And for the parent status, both of the majority of the more than 50% of the pediatrics were living with both parents. So coming to the clinical characteristics of the study participants, almost more than quarter of the study participants, the injury was due to road traffic accidents. Coming to the referral to rehabilitation units, almost 10% of the pediatric injury were referred to rehabilitation, either of one of the rehabilitation units. Looking on the patient status, almost 7% died in the hospital, with most of the patients, almost 50% died due to burn. Coming to psychometric property of the patient-specific functional scale, as I said before, we assess the PSFS at 3 time different points at the discharge, 2 weeks and 3 months. So if you look on the score, as I said that the PSFS is scored from 0 to 10. So at the discharge point, the mean score was 4.3, goes to 6.5, 2 weeks after discharge, and then goes to significant 9 score to the 3 months after discharge. So you can see there is a significant increase of the score of patient-specific functional scale to this patient. Coming to the content validity, checking on the flow effect and ceiling effect. So the flow effect was decreasing as time goes. So it decreased significantly to the 3 months post-discharge. This shows that this tool, it assesses less flow effect as time goes. But the ceiling effect was increasing as time goes. So this shows that the tools will be valid on measuring the injury. When coming to the mean difference score from discharge to 3 months after the discharge, we have the mean difference of 4.8. So in the pediatric trauma registry, there's 2 scales which were used in assessing the functional change. The other scale was GOSE, extended for pediatrics. So I tried to correlate the 2 tools together, the PSFS and GOS PEDI. So at the end of the day, I realized there is a negative correlation between these 2 tools. So this is show that the PSFS is the self-reported outcome, while the GOS extended PED is a tool with a scale whereby the clinician will ask a set of questions so that we grade according to the response to the patient. So there is a significant negative correlation between these 2. So these 2, they can work together to assess different function in this group. Coming to the reliability, the Chrombatch alpha for the internal consistency of the tools, it was 90%. So if you look on the literature, they say that the Chrombatch alpha from 0.70 or 70% show that there is a good internal consistency. So for this case, this shows that this tool is reliable because it has the 90% internal consistency. So coming to the temporal stability, we have almost 89 interclass correlations, whereby so many literature has shown that the ICC of 0.75 is accepted for assessing the tools. So I move further to check the standard error of the measurement. Standard error of the measurement assessed because PSFS is the self-report. So I want to see how much that this diverge, the report diverge. So if you look on the standard error of measurement, it was almost 0.31. So if someone scored the PSFS score 4.5, so it can either be plus 0.3 or minus 0.3. So this standard error of measurement is good because it's less than 50% and really is acceptable. So if you look on these findings, the PSFS show that is reliable and valid to be used to assess the functional change pediatric injury patient at our setting. Coming to the disability adjusted life years, so in coming to the different specialties, so neurosurgery contributed almost much of the years of life lost, whereby almost to the overall, this was the discount rate of 3. The overall contribution, it was almost 1,600 years of life lost. Checking on the gender, the male had almost more than 50% contribution of disability adjusted life years. So what does this mean? If you come to the study area, which is KSMC, we have only one neurosurgeon. But if you look on the burden, the neurosurgeon contributes higher life lost as compared to other specialties. So there's something alarming here, so that we need to consider checking on how this resource can be implemented so that to lower down this impact on the neurosurgery specialty. So I move further, checking the diaries at the different age group. If you look on the chart, if you look the child age 6 to 11, they contributed higher DALYs as compared to other age group. And also this, if you look on this age, is the age where a child starts playing, maneuver so many issues. So something needs to be done on this age group so that to lower this disability adjusted life years. And if you look on the years lives with disability, if you look on the chart, on the bar, almost at all age group, the years of life disability contributed much on the DALYs as compared to the years of life lost. So what does this mean? It means that majority of the pediatric injury, when they being discharged going home, they generate some kind of disability. If you generate some kind of disability, it means that you are in the risk of the quality of life will be poor quality of life, and also they'll be failing to perform their daily activities. So this high years of life living with the disability is something which need to be also considering in the intervention. So this would not be possible without the support from mentorship of GEMINI, also the sponsor of TRECK B43, my supervisors, mentors, KCRI, and KSNU. Thank you very much for listening.
Great. Unanswered questions for Baraka?
So Baraka, a lot of work, and as usual, you managed to keep going and carrying it on. So it's great to see how it's getting sustained with the data you're generating. So kudos to that. I remember when we were talking about this in Tanzania, there was a lot of discussion around the PSFS over time that it has missing. I see you fixed that, so that's really good to see. Like now, as a psychometrician, if I look at your psychometric results, and it's there's so much we can do there. And I want us to be clear on that because I think Liz is listening and Catherine is there as well. There's so much we can publish on the PSFS on this data that could sustain the use of the PSFS on trials, on other things. So I think there's opportunity for us here to really dive into the PSFS in this space and evaluate if it is a good and reliable tool. So I would like to do that with a little bit more caution. So I think there's more than one report to be made out of the data that is coming out. And we can talk that through, and that's something I want to talk to you before you leave. Okay, go through those results you show. I have some concerns. I like the Cronfax alpha. I like that you did the SEM. We can probably go forward and look at some other MCIDs out of that. I'm skeptical on your temporal stability because I talked to you about this in Tanzania. I don't think the data designed to show temporal stability, and we have to kind of go through that a little bit to make sure that the assumptions you have to show temporal stability make sense. And I'm not 100% sure about that, but we can talk that through. But overall, I think there's some other things to do there. Just on looking at the content of the activities they chose for the PSFS, trying to illustrate that content based on the different conditions they have. I think there's pieces there to do. Okay, but overall, I really like what you're doing.
I have a question for you, Joao, just so I understand the temporal stability. Isn't what we're trying to do after the hospital is to show the opposite of temporal stability? Is that we're trying to make these kiddos get better, and that's what makes it hard to demonstrate temporal stability because kids should get better after hospital stay?
Exactly, yes. So if you're correlating 2 time points after the event and you're expecting an improvement, you kind of don't want it to have temporal stability. You want to be able to detect the change. So what I think you're showing is that there's a high correlation between 2 time points at follow-up. And maybe that high correlation is because these patients reach a ceiling of recovery at a certain level. And that's what you're showing stability for, but it's not designed to show stability. So one might argue that your good result for temporal stability points out to a bad responsiveness of the scale to change. So that's why I want to be cautious of what we're saying, because I don't think that that's the case. I think that's probably a ceiling situation, which is not bad. But if we put out as temporal stability, it might sound like problematic psychometric evidence.
I know we have to move forward, but I wanted to point out something that I dropped in the chat, which is about the term accident. And you might have only said it once, but for some of us that have been working in injury prevention stuff for a long time, there's like this trigger that goes off when I hear the word accident in a academic context. If my mom tells me she saw a car accident on the road, I don't mind. But when we're talking about academics, we really try to avoid the word accident. Because it sort of suggests that these things are unavoidable, which is exactly the opposite of what we would say. So I dropped a link in here, but there's various terms. It depends who you're speaking to, what their preference is, crash, motor vehicle incident, different things. But anything but accident will make me happy.
Other thing that
I
sorry, Ashley, the other thing I wanted to bring up, and it's a little bit to help your introduction, Baraka, because I can't help on the psychometrics, but I can help on the introduction. You talk a lot about pediatric deaths, and then you switch into that's why we need rehabilitation. But kiddos who die don't actually need rehabilitation, right? So what we need to make the argument for, and we've done this in adults, is that as we start to build the health system and we start to save kiddos that would have died in the past, they're going to need even more rehabilitation. So if we know what we need now, it's only going to increase in the future as our health system gets better. And we actually have data in the adult world that this is the case, is that we're having deaths go down and disabilities go up from traumatic brain injury, from injuries at KCMC. And that's because the health system is improving. So the argument really is, even right now, while we have all these kiddos dying, there's a lot of kiddos that are surviving and need rehab. But as we save more and more kiddos, as our health system gets better, we're going to need double and triple the amount of rehab services.
Thank you.
Very cool. Nicely done.
All right. So I'm going to move us forward. But if you guys have other comments, questions, discussion you want to have with Baraka, please go for it. You know where to find them. So I'll turn it over to Miriam, who is going to present on her work. Miriam, while Baraka is doing the PhD program, Miriam is in the master's program in the same department. So Karibu, Miriam.
Asante, can you hear me?
Yep.
Okay, good morning to you all and good evening to you all. I'll be taking you through my thesis, and for this, I really need your inputs. So my title is Predictors and Outcomes of Time to Surgery Among Orthopedic Trauma Patients in KSMC, and it will be a mixed method study. So I have some definitions. Let me go to definitions. So I'll be using time to surgery as time from injury to time to surgery, and trauma will be defined as either a wound or injury to the body that has been caused by an external force, which can be a result from road traffic crashes. And orthopedic surgery This is a branch of surgery that is focused on treatments of musculoskeletal systems, including bones, joints, ligaments, tendons, muscles, and nerves. Introducing this, among the working group, we can see globally 5 to 6 million trauma-related deaths each year, and this is surpassing communicable diseases combined, let's say AIDS, TB, malaria, and even COVID-19 combined. It's killing more people as compared to any other cause. And unfortunately, among these who die, we have many, many more who are left with disabilities. But these disabilities can be prevented by either injury prevention or quality surgical care after a person has sustained trauma. So it is thought that delays in surgical interventions in emergency conditions can have consequences that can even lead to death or disability and deterioration of patients. So what is the situation at KSMC? In a paper that has been done recently, it just found out that there have been a 35% increase in orthopedic burden compared to 2015. And among 96% of patients who were indicated for surgical fixation, only 44.5, which is nearly half of those who were indicated, received definitive treatment of fractures and other orthopedic issues. But unfortunately, among these, the orthopedic trauma patients, they have not been a study really to look at the association between the timeliness of even the few surgeries that are done to the outcomes that the patients have. And my study is aiming to close that gap and see what are the hindrances, what are the factors that contribute to this timeliness of the surgeries. So my problem, as I said, Tanzania currently has a lot of victims of trauma, and it is assumed that 15.8 per 1,100 deaths are from trauma in Tanzania. And outcomes are not good, depending on timeliness of the surgical care among patients. And my broad objective will be to determine the predictors and outcomes of time to surgery among orthopedic trauma patients in a tertiary hospital in Tanzania, with my specific objectives being to determine time to surgery among trauma patients undergoing orthopedic surgery. My second objective being to look at the association between time to surgery and the outcomes. And my third objective will be to explore the factors contributing to time to surgery. So this study is going to be a mixed method study where I'll do the quantitative part using the retrospective cohort study design, using data that I will use the KSMC trauma registry that is dated from 2020-2023. And the qualitative part, I will do IDIs and focus group discussions with patients and emergency plus orthopedic healthcare workers. So my study area will be the KSMC Zone Referral Hospital, with my inclusion criteria being orthopedic trauma patients treated surgically from 2020-2023 for the quantitative part. So in my methodology, my dependent variable will be time from injury or time from arrival to time to surgery, with my independent variables looking mainly at the demographic characteristics and clinical characteristics. So my analysis plan, this is where I need a lot of help actually. So for the objective 1, where I'll be determining time to surgery, I was thinking of using the 3 delay model, but unfortunately, I'm not sure if the data is going to support the 3 delay models, as in the PRACT registry, we have time at injury, time at arrival at the EMD, and time for surgery. So delay 1 and delay 2 might not be very distinct, and I think maybe you can have some thoughts how I can undergo that and make it more better. And also, I'm also thinking about the categorization of time. I still feel that it is very, very important to make a distinction between emergency and elective cases, because as we know, the need of surgery between emergency and elective cases might be very, very different to these two groups. And we have some issues with missingness of data, maybe doing an imputation methods so that we can at least categorize these patients into emergency and elective cases. I really need to hear your thoughts about this. And for the objective 2, I'll be looking at the association between time to surgery and the outcomes. So far, I have already identified confounders through literature. And for this objective, I'm looking forward to perform a logistic analysis, which also has some issues, as I am not sure if it is as fancy enough as my teachers back in KSMC would want it to be. And I really also need some inputs on this. So in doing a logistic analysis, I'll have my outcomes, and I am planning to put these outcomes into, so also here I'll need some inputs. So the first way I thought of it, it's either I could use the GOS-E score, where 1 to 4 could be poor outcomes and 5 to 8 could be good outcomes, or I could either divide it into good versus poor outcomes, with poor outcomes being a combination of things, including mortality, morbidity, length, hospital stays, and acute surgical consequences like surgical site infection. And my independent variable will be time to surgery, that is injury to surgery or ED to surgery. And my third objective will be exploring factors contributing to time to surgery. And this will be done, I will record the interviews, I'll translate and transcribe, and later create a code book, and then create a descriptive summary of the statements. So what is next? Currently, I've received my KSMC IRB, so I'm working on getting my NIMRI IRB. And here I've tried to contact Ashley, so she's also working on my IRB approval so that I can access the data and start with data cleaning. So currently, as I said, I will need a lot of inputs in my data analysis plan. I feel like there are some gaps that need to be filled, and a discussion will do. Yeah, these are my references, and this is my great time at Duke and in Washington. It has been a very great time here, and thank you all. Thank you for this program giving me this opportunity. And last but not least, here is my ID. Actually, as I told Catherine, I have never smiled in an ID, and this is actually the first time. And I'm keeping this forever. Thank you.
Awesome. Questions or comments for Miriam?
I have some, but I'd love to hear from the group if they have any thoughts or feedback.
Hello.
Yes.
So thank you, Miriam, for a nice presentation. I think we had a talk about this. So concerning the analysis of the 3 delays, actually it's not possible to analyze it exactly like the way the original 3 delays is, but we can modify the analysis. I did the same thing. I did modify mine, and because the 3rd delay actually was the longest, so I divided the 3rd delay because it was possible with the data. I divided the 3rd delay from the time the person reached the EMD to when this person reached the ward. So this was telling me how long this person was spending at the EMD and the issues of investigations and things like that. And then the time this person stays in the ward. So the time when this person reached the ward and when the surgery started. So you can see that the third delay is now splitted into two. And then the first delay, because we do not have the time this person decided to reach care, we have to combine it. So from the time injury was encountered to when this person reached the DNB. So the first and second delay are made one delay. The first delay in your study, then the third delay is now split into two. I think you might find the same results, that the third delay will be the longest. Maybe I think you might find the same results. So it will be easy to explain why you have done that you have splitted the third delay to know exactly where the problem is. Yeah, thank you.
Thank you, Rosa.
Thank you,
That's
Rosalia.
great.
I think Rosalia's experience is going to be really helpful for you, Miriam. So definitely please touch base with her about her experience. But one thing that differentiates her project from your project is the specificity of her project. She had a very specific fracture that she pulled out. And the reason she did that is because she was able to have a timeline of recommendations of if you should have surgery or not. If we look at all orthopedic fractures, not every fracture requires surgery. So part of what you're going to have to plan to handle is, what about the patients that don't need it? How are you going to know that they don't need surgery? Or maybe they need it, but they can't get it because of some reason, and that might not be in the data. Or maybe they need it, but it's delayed for some logistic reason, which is essentially what your project is, right? So there's a gray area between this, like, we don't know who doesn't need it. We don't know who needs it, but is having a barrier of some resource that's at the hospital. And then ultimately the people who never get it, whether or not they needed it or not. And so thinking through how you're going to differentiate these three groups, and make the data sort of help you understand what that means, I think is going to be really important, because there are some things that never need surgery, right? And we shouldn't be comparing those to others that do. So really important and interesting topic. A couple of little areas still to build out there for that clinical support. Nicely done.
Thank you, Catherine.
Miriam,
Yes, ma'am.
going to the objective number 2, looking on the association. If you look on the paper with Elizabeth Keating, they categorized the GOSE into 2 groups, whereby the category of 1 to 2, it was a good recovery. Greater than 2, it was a poor recovery. I think we can just open that option. Coming to the analysis, looking on the nature of the objectives, because we have the time component. If you use logistic regression, we either over or underestimate the effect. So for that case, you can just use the survival analysis to consider individual contribution to each time point, so that at the end of the day, you have something which is realistic. So I just advise to use survival analysis because of the time component, so that you will not over or underestimate the effect. Thank you.
Do you understand, Miriam?
Yes, but I feel like, how am I going to interpret my results with the survival analysis? I feel like the logistic analysis better fits my objective and how to interpret the results.
Suggestions there?
Because
I guess,
okay.
no, but I guess in the end, I think if you're trying to model time, survival is always better. If you're trying to model delay, then logistic might be better. But we go back to that discussion we had in Tanzania, that delay is not clearly defined. So you might need to model time to see if you can infer delay. Now, that for me is gonna be tricky. I think we need to discuss this further. So we can try to use the Wednesday time with the TRECK students to discuss this further, or have a different time. But I think this is the part you need to sort out. The rest seems a bit more straightforward.
Thank you, Joan.
Sure.
One other thing, Miriam, is that I'm gonna invite you to talk to the trauma continuum team. There are orthopedics that are there at that meeting. I would love to get their input in terms of what they think is most important, because then we can use this information clinically for the orthopedic department. So I know Rosalia is getting prepared to present her data. Please join her as she presents, so maybe you can hear sort of what happens and the feedback they give her. And then also plan to present your thesis topic as well.
Okay, Catherine.
All right, we're gonna leave it there so that we can get through some paper updates, but again, if you have other comments or questions for Miriam, I'm sure she would be happy to hear them offline, so get in touch on Teams or elsewhere. And we'll go ahead and go through our updates as quickly as we can. Thanks to you both for sharing.